Good afternoon, everybody. Thanks for joining us again today in the Native Strong Town Hall on our COVID-19 pandemic and the response within the Native community in Wisconsin, in Milwaukee, the Bemidji area, and of course, as always, we're with our featured speaker, Dr. Lyle Ignace of the Gerald L. Ignace Indian Health Center. Some quick updates. Dr. Ignace actually was one of the first, maybe if not the first, doctor in the Milwaukee area to receive the vaccine on Tuesday afternoon around 4 o'clock. So we're pretty excited about that, to obviously hear from him today about his experience, any side effects or feelings afterwards, and probably just give us a little more updates on the vaccine, kind of how it's being dispersed and all that as well as updates on numbers and whatnot. For all of those who have joined us before, we love your interaction. We love your questions. So please enter them below in the chat box. If you are tuning in via Zoom, just towards the bottom of the screen, there's a little chat bubble. Just drop them there. Otherwise, if you are joining us via Facebook Live, you can enter as a comment. As we go along here, I'm going to share a video with you a little bit later of Dr. Ignace actually getting the vaccine. So it may be a little choppy, but I'll also share the link out so you can watch it on YouTube or Facebook if you like at a later time. So with that, I'm going to pass you off to our moderator, Mark Denning. Thanks again for joining us, Mark.
Winnabuju and we Maganaduk, Hadaway Benazi, Indigenous cause, the main do them, Anishinaabe and Dow, Neopid Donjaba. Good afternoon, everybody, and welcome again. I think we're going to be talking about some very exciting things today. With great happiness and also in great seriousness for a couple of reasons. One is certainly we've been hearing about the vaccine, and also we've been hearing about numbers that have been going down. But we're also realistic to know enough that it'll be a while before a lot of the folks on the front lines, the majority of them have the vaccine, and even when it's available to that daily worker that's out there. So while it's a day to celebrate, it's also a cautionary tale that we need to be looking out for each other and taking care of each other. Also, like everyone to just reflect in this historic moment that was yesterday when people were in Wisconsin were getting this vaccine, that this effort was led by both private industry and the public health, like the Center for Disease Control, like our own Gerald L. Ignace Health Center is a part of that story. And I know that there's a lot of suspicion out there in our community about, is this something I want to be a part of? Should this be something I want to be a part of? And I'm just going to have everybody just take a pause, take a beat, and just reflect back, if you might, to the year 1993. And there was a virus that our country was facing, and it was called the Four Corners disease. And eventually the CDC, its investigations found out that it actually was a hantavirus, a virus that needed to be put in check because people were passing away when they were encountering this virus. And I think because of the generational span of time, we've forgotten about that story. We've forgotten about when science combined with our culture to defeat a virus that was threatening Native and other lives that were in that Four Corners area. We have that on a larger scale now. And we need to be paying attention that there has been good work done by science in our communities before, and it's been successful. So please remember that when you're talking about what we're doing today, because it's not as if we haven't done similar work before. So with that, I'm going to turn this over to Dr. Ignace here on your screen. I'm glad to see you, Dr. Ignace. You don't have two heads. A lot of our community members are thinking, oh boy, that guy, next time you see him on screen, he might have a big, huge bump here. Yeah. And there was also some concern that you get a juice box with your shot. There was some questions about that. So suckers or juice boxes, we're not sure if that's available. So I'm sure we'll go into that. But without further ado, relatives, let's check out what Dr. Ignace has to say, and let's get some updates for our good community. Okay,
Absolutely.
Dr. Ignace, turn it over.
Absolutely, thank you. Thank you, Mark. Thank you, Jeremiah. This is, we're going week 35. Yeah, exciting news, and welcome back. A lot of things have happened since we last spoke, and I'm going to try to get you up to speed as to what's going on. Just as Jeremiah had mentioned, Wisconsin, it's all about the vaccine right now. Pfizer rolled out its vaccine, and Wisconsin got its first batches. And after everyone was making headlines to getting the vaccine, looking at all of the review and all the articles that came up, I think I may have been the first doctor in Milwaukee to get the shot. I think. I'm pretty sure. At least that's what the Journal Sentinel's telling me. So anyway, so we're here, Operation Warp Speed. It is in full swing right now. Yeah, as everyone is aware, Pfizer has been approved. It's rolled out. Medurna is on deck now. And in fact, they are, just like last week when we were talking, the FDA advisory committee is speaking about the data, the analysis, and they're going to approve their recommendations more than likely today, probably while we're still talking. And just like last week, the FDA will approve, the institution FDA will approve it, and we're off to the races again with Medurna. So that's where we're at. Pfizer rolls out. This has been a big week for vaccines. Medurna is up. And so just so we're all on the same page, the CDC has also weighed in as well, and they've given their recommendations as to who should get this first round, this first allotment of vaccine. And how this is working out is that the CDC's come out with this phase 1A, 1B, and they're going to come out with a 1C here shortly. But as of right now, it's 1A, and this is really the healthcare workers, these frontline workers, first responders, ambulance, firefighters, and hospital ERs, ICUs. They're all part of this group. And it's estimated that it is about 20 million people. So that's who a good portion of this vaccine is going to right now. Phase 1B is obviously the individuals, nursing home, long-term care facility, assisted living, group home individuals that will be getting the vaccine as well. It's estimated as about 1% of the population, just under 3 million individuals. But the main concern is that this subgroup population accounts for 40% of all fatalities throughout the country. So you can see where this distribution and allocation is being very strategic in how we address not only the hospitalization, but also who would benefit the most, who would be impacted the most by being able to reduce fatalities. And that is this age group. Now 1C is going to be, and you'll probably hear more about this in the coming weeks, but 1C, phase 1C is going to be the essential workers. And that's where there's going to be more discussion. And 1C is essential workers within the healthcare setting. So, and then after that, it's phase 2, and with high-risk individuals that make up, close to 90 million people in the country, and then phase 3 for the general population as a whole. So, just like Jeremiah said, I got my vaccine, and this was really it was kind of an interesting how this all kind of rolled out. Now, last week I had mentioned that there were going to be agencies, federal agencies that were going to get the vaccine first. IHS, Indian Health Service, was one of them. We could have gone with the state, DHS, on the vaccine. We went with IHS only because I knew it was part of the federal system and that IHS has been heavily involved in a lot of the discussion up to this point. So I knew we would have a pretty good opportunity of receiving this vaccine in very short order, and that's exactly what happened. So once FDA, CDC weighed in, gave their approval and their recommendations, it was shipped out to IHS for our area. On the very next day, it was shipped out to Wisconsin. One of our employees literally had to get in his own car, drive up to Green Bay, go to the airport, had to sign off on a bunch of things, was given the package. That package made its way down from Green Bay to Milwaukee. And by 2 o'clock on Tuesday, we had our vaccine. And so from there, obviously we have our staff prepped. We had our individuals assigned who were going to get our first allotment of vaccine. So let me turn this over to Jeremiah so we can see this video clip. Jeremiah, you're on mute on your side. So just so you know, I was speaking in the video. I basically outlined kind of the process by which we took to this point, and just talking about after obtaining the vaccine, how we were able to prep the vials and really, you know, I was a bit nervous, but excited at the same time, mainly because this is, you know, for us in the Native community, it is part of history. And as I mentioned, this whole time, as I've been talking about, you know, developments, therapeutics, what was going to happen, that I was going to be that first person, that I didn't have issue or concern about the process by which the vaccine was developed. And I felt confident and reassured through the FDA that this vaccine was going to be beneficial, not just for myself, my family, but as the community. And I think it's important that people understand that this vaccine was safe. I really didn't feel anything. If anything, as much as a mosquito bite at best. So it wasn't that bad. It really wasn't that bad. So so I got my shot, and I had to be observed for a good 15 minutes. I did not have any immediate side effects or reaction to the medication or to the vaccine. So that process went fairly smoothly. The other individuals that were assigned to get the vaccine, they also went through the same process. We were all observed. After about 30 minutes, we kind of looked at each other like looking at each other as like, what's the big deal? Felt very much, for people who've gotten the flu vaccine, felt very much the same as that. So, it felt good to be part of that first group. And I do have a sense of pride in this because I do believe in the benefits of science and the benefit of vaccines. So I really didn't have a problem being first to get it. And I think it's important to not only demonstrate how safe this is, but I've been talking about this vaccine for months. And people who've been watching this town hall certainly can appreciate how much I've been talking about this vaccine to this point. So that was the immediate. Now, the Pfizer vaccine does have a profile of side effects. And these are the side effects that have been primarily listed out. Site injection soreness, some tiredness, headaches, joint pain, swelling or redness at the site, maybe nauseated, swollen lymph nodes, mild aches, low-grade temp within 24 hours. There's been no short or long-term side effects or adverse events noted. So getting the shot, I really didn't feel anything, felt fine. I went home, felt fine. The next day, I felt okay, but as the day wore on, I did have a sense of feeling tired. Kind of like one of those, when you haven't slept the night before very well, and the next day you just kind of feel, getting tired. Well, that's essentially how I felt. I didn't feel like I was sitting here and I could fall over and sleep. No, I just felt just tired. I had no headaches. I had some soreness from the shot. My appetite was fine. I didn't have any swollen lymph nodes, no body aches, no fevers, and I had kind of this weird sense of some swelling, or at least a sense of swelling in my my hands, my joints in my hands. But I did take an ibuprofen, and that seemed to resolve that sensation. It never caused me any pain. At no point was I ever in any pain or discomfort. So went to sleep, woke up this morning, I actually felt pretty good, pretty much back to my normal self. So if that was my 24 hours, I didn't think that was much of a side effect, at least for me. Now, the others I did talk to who did receive the vaccine, I think one individual said they had some headaches, but they couldn't tell if that was headaches from just their normal kind of headaches that they get, or it was from the vaccine. They couldn't tell. Somebody had nausea. One person kind of felt achy and a low-grade temp, but today, all of those symptoms have resolved for all these individuals. So actually went pretty well, I thought, and no one has indicated any significant side effects, and if anything, they would rate these as being pretty mild. Nothing that a Tylenol or an ibuprofen, certainly couldn't reduce or eliminate. So we kind of went through our own trial here of our individuals, and no adverse events had occurred, and mild side effects, I would say, or nothing for the most part. So I certainly felt very comfortable now being 36 hours out I feel pretty good. I even got my vaccine card. I got my vaccine. I won't show you my birthday, but I got my vaccine card. Here it is, CDC formal vaccine card. I got to get first dose, second dose will be in 3 weeks. So that'll be official. So let's talk about Medurna. As I mentioned, the FDA Advisory Committee is meeting right now. They will be giving their formal approval for recommendations once their process is complete. But it's anticipated that they will follow suit, just like Medurna, like Pfizer has. Now, just so everybody knows, the U.S. has already entered into agreement a long time ago, probably early summer, with the purchase of the first 100 million doses, and just recently had agreed for an additional 100 million doses. Now, just like Pfizer, the process will be after the FDA agency signs off, gets approval and signs off. Basically, the shipments are to arrive 24 hours after this agreement is initiated. So the only difference with Medurna and Pfizer is that they feel they can distribute close to 6 million doses and to over 3,200 sites, which is 4 times more than what Pfizer was able to do when they got approved. So there will be definitely more vaccines as early as Monday. And we anticipate here at our agency to get our allotment to complete our campaign here at our facility on Monday. So this is actually pretty good news. First ones here for Pfizer. I suspect we'll be first ones with Medurna. And we're off to the races again, vaccinating more people. Now, one thing I just want to kind of highlight is there any comparable differences between Pfizer and Medurna? And the bottom line really is not really. They're very similar. They're off of the same platform, the messenger RNA technology. They both use it. Very minor differences is the dosing. Pfizer on day 1, their second dose, both require 2 doses. The second one for Pfizer is 21 days after the first. Medurna is 28 days. The effectiveness, pretty much the same, 95% for Pfizer, for Medurna 94.5%. The subtle differences in the subgroups that have been studied is that Pfizer says it's 93.7% effective in people 56 and older, and Medurna's vaccine 100% effective in 65 and older in preventing severe cases. So it's very subtle on how they word the differences, but just rest assured that it is extremely effective across the board. As you can see, it's effective against all age groups, gender, and racial and ethnic groups. There were no adverse events in either trials. In the trials, we heard about adverse events after in the UK and the anaphylactic reactions. And people have probably heard maybe the other case here in the United States, in Alaska. With Pfizer, 16 and older, it's been approved for. In Medurna, it'll be 18 and older. So aside from that, there really isn't a whole lot of difference between the 2 vaccines. So, you know, one is certainly not better than the other. I think from a logistic coordination standpoint, it was probably harder with the vaccine for Pfizer, only because of its deep cold storage. With Medurna, it's going to be a lot easier to distribute in bulk compared to Pfizer, only because you don't need to keep the vaccine in this deep freeze. So Medurna may actually weigh out better only because of its ability to distribute. profile side effects are pretty much the same. So there really isn't anything remarkably different between the two. And I would certainly endorse Medurna's vaccine once it comes out for the general population, and even for anybody who wants the vaccine. It really doesn't matter if you get the Pfizer or the Medurna. Its profiles are essentially the same. So, as I mentioned, the FDA Advisory Committee is meeting right now. They will go ahead and review and provide their vote for recommendation. FDA, Dr. Hahn, will give its approval. Hopefully, he'll give it even tonight. And then CDC will weigh in with its recommendations, but essentially, it's going to be the same of what Pfizer is, and so they'll be able to distribute this in earnest and get these off and get them into facilities and sites first thing Monday. So let's get into some numbers. As of yesterday, we have seen there's almost 74 million cases worldwide, 1.6 million fatalities here in the United States, 15 million cases. We've tested 220 COVID tests have been done. 440, nearly 445,000 cases here in Wisconsin. Almost 400,000 have recovered. And the fatalities, 4,196. We'll get into the numbers, straight into the numbers with Indian Health Service. So as you see from left to right, we have the 12 areas within the Indian Health Service throughout the country. The total number of tests being done in that area and the total number of positives. So as you see in the angled December 14th column, you see the areas that are highlighted yellow. These are the sites, the areas in the country that are still demonstrating high numbers of cases. And over the last 5-6 weeks, we've seen from all areas really highlighted yellow to now we're getting more into a concentrated area of Navajo, Oklahoma City, and Phoenix. So that's really, we're talking about southwest region of the country. And these are the areas that are heavily impacted by continuation of COVID and its surges. All the other areas seem to be receding now. And as of December 14th, 8,000 cases. That is down from a week ago. And about what we were doing towards the end of November. So hopefully this is a beginning here, a trend of hopefully we'll see a downward trend across the board. But overall, it's still high across Indian country, in particular in these three areas, Navajo, Oklahoma City, and Phoenix. So looking at some regions very specifically, we know there's differences between IHS and differences of cases being reported outside of the Indian Health Service. This is just showing that there are definitely cases that are ongoing outside of our federal, tribal, and urban programs in the public and private sector. And this is really just trying to illustrate the differences. There are definitely natives being diagnosed with COVID outside of IHS. And we need to recognize and at least acknowledge that the numbers are going to be higher than what IHS has been listing, at least 40% higher than what IHS is listing out right now. So as you just scroll through this, you can see that different parts, different states, all heavily populated with a native population, all exhibit different profiles of numbers, and you can see that some states are pretty high in numbers, and some are not insignificant, but they're definitely on the lower end of the spectrum here. So as we walk through the states here in the Midwest, we see that there's kind of this Wisconsin, Michigan, Indiana all now have this very similar profile of cases overall. Minnesota's kind of a distant fifth, and Illinois obviously being the highest number in our area. So as we look through the states, more specifically to the tribes, the 12 tribes in Michigan and their respective counties, as we go from left to right, you see the November 11th, 18th, December 9th, 16th. Those are the number of new cases per county with respect to the 12 tribes. And overall, the numbers are pretty flat. There's really no acceleration of cases. Some have been flat, some have been decreasing significantly. So overall, the state of Michigan, the number of native cases appears to be decreasing. Currently, there's 2,160 cases, 160 new cases, native cases in the past week. Of that 2,160, it represents 3.6% of the native population in Michigan has now been confirmed positive for COVID. So remember that number 3.6, it seems to be kind of, it's on the low side. In Minnesota, with respect to the 11 tribes and their counties that they reside in, again, looking from left to right, we look at the number of new cases in the past week. And again, we see this, there is a trend of either being flat or decreasing. And that's really what the numbers show for the state of Minnesota. 3,562 cases, confirmed native cases, 217 new cases in the past week. And of the overall number of cases, this represents 4.7% of natives in Minnesota have been confirmed having COVID. Here in the home state of Wisconsin, my home state of Wisconsin, we have the 11 tribes and the counties. And with respect to the number of new cases in those counties, there really is one particular county that seems to be maintaining a very high level compared to the other tribes, and that's Menomonee County. Still having a fairly significant number of cases, and appears to not, doesn't appear to be a trend downwards. In fact, in the past week, it seems to be tracking back upwards. So as of yesterday, 5,777 cases total, 346 cases this past week. Of the overall number, total number of cases to the native population, it now represents 11.2% of the state's native of Wisconsin have been confirmed positive. And I'll come back to that number towards the end, why that's pretty significant. So I've been also tracking kind of the trends as to the counties here in Wisconsin outside of the reservation. So, so as you see, December 2nd, December 4th, December 16th, you can see that, you know, the week of the 2nd and 6th, you see the trend of cases tend to primarily be in the west, in the northwest part of the state. As of yesterday, it seems to be more localizing to the northwestern part of the state near Asheville, Red Lake, Red Cliff and Bad River, getting into the Duluth, Lake Superior area, and it seems to be really concentrating in that northwest part of the state. Looking at things from a national perspective, this is the number of cases per 100,000. And you can see the trends that have been going on since November 25th to the 4th to the 9th, and as of yesterday, you see that where in November it was very concentrated in the upper northern Midwest and the northern plains. As time has gone by, you can kind of see how it's just receding. It's not as dark blue as it used to be, and so there is a regression of cases ongoing in the north, in the plains, and in the upper northern Midwest areas. It seems to be now concentrating more in the southern states and on the coast, and that's what it appears to be trending right now. This slide is more about just cases that have been ongoing. So we see that, December 9th, we have the number of cases. We see the states, California, Texas, Ohio, Pennsylvania, Illinois, Florida as being kind of the top tier. We used to be in that top tier. Not too long ago, like 4 weeks ago, we were like number 2 in the country in the total number of cases. Well, things have changed over the last 3 weeks. Things have changed for Wisconsin and our residing states next to us, where now we see California, Texas, Pennsylvania, Ohio, Florida, Illinois. Those are the same tiered, high tier groups. That hasn't changed. It's just the order by which who wants to be have the most. But clearly it is California now, far exceeding all other cases per state. You see Wisconsin is just keeps dropping and dropping and dropping and dropping. And so when we look at the overall number of cases in the past week, almost 1.5 million cases in the last 7 days throughout the United States. But if you look at it in a little more detail and kind of give context to that number, we can see that 35% of all of the cases in the United States are because of these 6 states, which is a pretty significant amount given, 50 states. We have 335 million people in the country. 6 states make up 35% of all of the cases. So that's pretty significant. And if you look closer, you see that California is the number 1 by far, almost triple the number in Texas and any other state. So what's really driving the numbers right now is California. California is definitely driving the numbers throughout the state. So when you hear how many cases we have, yes, all states are involved, but there are a few states that are making up the vast majority of all these cases. So do take that with a grain of salt when you hear it on the news. Now, when we look at age demographics, really no significant change in the ratios. However, as you see, I track these on a weekly basis. Ever since September 9th, I've been very meticulous about how we track these numbers, and over time, you can see as of December 16th, our numbers are continually decreasing, and they're decreasing across the board with every age group, and pretty much consistent in terms of numbers. Once you get into the 20, 30, 40, 50, 60-year-olds, pretty consistent in terms of ratio of numbers. What's decreasing is the 10 to 19-year-olds and the 0 to 9. We haven't really seen these kind of numbers since mid-October. And that's kind of where we're heading right now. The numbers, the trends this week have indicated that it's going to continue to go down. So the trend is looking actually quite good for Wisconsin right now. And this, with the 7-day average, you see that we had this high spike mid-November. I know we all had heard and were concerned, and on the news and all throughout the country, Thanksgiving's coming, hunting season was coming, and that we all had to modify our Thanksgiving for fear that it was going to surge. Well, we kind of blew right through the surge, and Thanksgiving has not really created the impact I think everyone was fearful of occurring. Hunting season did not cause a surge. Thanksgiving has not really caused the surge. We have even more people at home now. So how can one explain why that is the case where everywhere else in the country it's maybe a different picture? Well, I think for Wisconsin, we had our surge before Thanksgiving. Every other state didn't have this kind of surge until now. So whether or not their surge is due to Thanksgiving, I think is mainly really as a coincidence as opposed to truly as a result of Thanksgiving. If that was true of all Thanksgiving, all getting together, causing a surge, we would have seen a second wave spike up, and we really didn't. We maybe had a blip, maybe a day or two of maybe this could be the beginning, but it really didn't pan out, and the numbers are continually going down. And so, like I said, we haven't really seen these kind of numbers since mid-October. And if the trend continues as it is, as we're going into the weekend, where typically the numbers tend to go down, we could be seeing coming out of this weekend on Monday and Tuesday, the numbers will be even lower. So right now, Wisconsin is actually looking and faring much better than most states. As we're on the way down, other states are still on the rise, or maybe they're plateauing. It's just that we had our surge weeks before the other states have. So here's Menomonee County in terms of the hospitalizations. I know we all hear about hospitalizations and concerned about overflow, but for us here in Milwaukee, the admissions, the discharges, they've been consistent. Our hospitalization system has not been overrun. Now, there may be some hospitals in the state that may be kind of reaching that red line, but for the most part here in Milwaukee, our health system has actually fared extremely well, and the number of people in the hospital is starting to decrease, which is a good sign. Now, a couple of numbers. I had mentioned that I wanted people to pay attention. I mentioned that Wisconsin was at 11.2% of the native population has had COVID. Now, if you look at the lower half of this table, if you look at the left lower quadrant area, you could see how this is all states' demographics and overall total. So you go in the percent of cases, the number of cases as you go down, you see a number of 8.03%. That is the number of cases confirmed of COVID in the entire state, regardless of race or ethnic group. That's overall 8%. Now, if you include the estimated asymptomatic, which could be as high as 10, 20, 30% more cases that just have no symptoms or have mild symptoms but never got tested, if you add that in, we are now looking at 10.4%. 10.4% of the state overall is presumed to have had COVID right now, 10.4. I had mentioned Wisconsin's native population just confirmed. We're not even talking about the asymptomatic or mild symptoms that never got tested. We're talking about 11.2% of the native population. So by far, the number of confirmed cases far exceed the general population of Wisconsin. So this is an alarming statistic that I think everyone should be mindful that the native population is most certainly impacted by this virus deeply. So And then as you look on the lower right-hand side, you see the number of cases in the past week, the number of hospitalizations, ICUs, and fatalities. I highlighted the age group of 60, 70, and 80. Now you can see the number of cases per age group. They are the lowest. They are make up the lowest number compared to the younger age groups, but they make up more hospitalizations, both on the floor, in the ICU, and they make up the vast majority of all fatalities. So I'm setting this up because once we get past this vaccine stage of phase 1A, 1B, we're going to be talking about who gets the next round, who is that next group of individuals. Yes, there will be other essential healthcare workers, but we need to talk about who needs to get it after that. Well, I'm highlighting who needs to get that next round. We're talking about the 60, 70, 80-year-old groups. We know that this virus tends to impact individuals who have the most risk of comorbidities, so such as high blood pressure, diabetes, lung disease, people who are undergoing treatment for cancer, transplants, autoimmune, all of these individuals, cardiovascular disease, neurovascular disease, all of these individuals we know have the highest risk for poor outcomes, not just in hospitalizations, but in fatalities. So this is the age group that needs to be vaccinated and who will have the biggest impact on hospitalization, on our hospital system, as well as fatalities. So with that, I'm trying to shorten this discussion up front so we have maybe more time to ask questions and have open discussions. So Mark and Jeremiah, I'll turn this back over to you guys.
Jeremiah, let's go to kind of the questions in order. We have a few. There was someone from Potawatomi area that wanted to be asked a live question. Is that possible, or do they need to write their question out into the chat box? Jeremiah?
Yeah, I'm, hold on, I can. Linda, can you unmute yourself? Oh, there you go.
Yeah, there we go. Good afternoon. Can you all
Hello.
hear me? Yo. Hi, Doc, and hi, Denny.
How you doing?
Here you guys. I haven't seen you for many moons. So, you guys hiding or what?
Yeah.
I recognize that voice.
Yeah. Doc, there I concur to you on your shot, and I got mine too, but I waited kind of the last minute to tell anybody that I was going to have it taken. And the symptoms that I had was about the same as yours, except for the hand part. Everything's cool. I feel fine, and all that good stuff. Ready to work out, do all this kind of stuff. But I keep myself moving, and that's pretty good. So I'm doing okay. My question, I have a question. Go ahead. Sorry.
Yep, I hear you.
Okay, my question is, the other day, like I mentioned to you, I didn't tell anybody until the last minute. And I told my family. They came up from Illinois, near where you reside there, Denny, down in Bloomington, really. And they came up and they wanted to talk to me. So they said, "Hey, Dad, we'll get you a lunch and everything. We'd like to talk to you." So I went to the hotel where they were staying. And so I sat there and we started talking. And I told them that, well, I'm going to get it today at 11. And they said to me, and so another group too was also questioning the same thing about the shots. And I don't know if I should say this in regards to our people in the past, the trusting and so forth like that in medicine. When they gave it to us and they did this, did that, well, the word genocide came up. They didn't want me to take it because they're giving everything to the tribal people. Majority of the shot, I guess the ratio of shots they saw that was being given to the Native Americans and stuff like that. Well, so I came back with them and says, well, I feel like I have to take it just to see, because I'm in good shape and stuff like that. And so, and I'm an elder. That's why they're giving it to me, I told them. And then the other part was the frontline employees are getting those shots too. So it's not just one-sided, I told them. It's everybody that's working in the industry for health and stuff to protect the people and help the people and so forth, the ones that are there that are getting the shot. So that was the question they came with me was they didn't want to take it because this is what they feel and seen. That the trust and stuff like that in regards to taking this shot and in regards to also to time limit, how quick it was to take it. So I wanted to pass that on to you.
Yeah, you bring up an interesting point because this vaccine has been very, very transparent, very much in the public's eye since day one. And what we're seeing with this rollout, with this national campaign, is that it's just not one particular racial or ethnic group, or it's it's across all. It's obviously the front healthcare people, frontline people, but you see all different walks of life, people who are who are visibly present and on camera taking this vaccine, and younger, older, women, men. It's just so transparent as to kind of, I wouldn't, it's really kind of looking at how we ease people's minds as to not just who's getting it, but in the manner in which they're getting it. It's very visible how people are getting shots. It's not like it's being faked or anything. And I mean, you see it with your own eyes. I'm telling you my own personal experience, the minimal side effects that I had, and I'm after 24, 36 hours, I'm really just like you were. Side effects were very minimal, and you feel like you're ready to get back into your normal routine. Now, I know who you are. Unfortunately, the golf courses are closed this time of year, but maybe you can get in some tee shots somewhere if you feel that good. I know how much you love golf. So, but again, setting that example, understanding, showing, and really expressing your thoughts and opinions as to getting this. Now, what's coming out right now is that the symptoms that people have, what they kind of if you wanted to compare side effects to COVID, well, now they're saying that the side effects of the vaccine are 10 times less than it would be as if you were to get a full-blown COVID. Now, that's the difference between getting vaccinated and not getting vaccinated. If this is all that I'm going to experience related to COVID by getting a vaccine and having some tiredness and maybe some sense of joint stiffness, I'll take that over having COVID any day. And I think, and that's, my personal experience, someone who I don't have any health related issues. And the alternative of getting COVID or falling ill to COVID, if I could avoid that, I absolutely will. And so decision for me is actually pretty clear and pretty easy in taking it. And I would recommend to not only my patients that I see, but also the Native community to get the vaccine.
Bujupo, so I want to build on what's being said, and this is the part where, as a lecturer, I start waving my hands because we have maybe 6 people on the call right now, but by next week we'll have 500 to 600 people kind of watching this and seeing what's going on. So I want to support the idea and the feeling out there in Indian country that there is a great distrust of the American government, and there's good reasons for it. There's a history of that, and so people are likely to say, hey, boy, I don't know about this one. I also would say that just as a real-time matter, yesterday during the Menomonee Forum, there's tribal members of Menomonee Nation that are going to be running for tribal legislature, that no one brought up COVID-19 as a pressing issue for the community. It didn't appear once. It's like a hot potato issue. No one wanted to touch it. And to my ears and what I was seeing, that should have been number one. Certainly because it is a thought and it is something that's threatening our community. So my answer to Native folks out there, and again, I'm waving my hands and moving about to get those people that run fast forward, is to, yes, look at our recent history. And that's why I brought up, why is this guy talking about 1993, about the hantavirus? Because that was a virus that had a 50% mortality rate of those who were infected by it. It was in lots of, for the students out there, you can look this up as Four Corners virus, Rialto Canyon virus, the Convict Creek virus, the Sin Nombre virus. You can look any of those terms up. Why I'm bringing this up is because this is where a nexus, where Indian country and the United States government have come together in the work of virus and public health. So what was happening, for those of you that may remember 1993, and I would add, this recently happened in 2012, was this virus made a reappearance in that same area in 2012. So we're just talking 8 years ago. This is a case where the United States government worked in concert with sovereign tribal governments, healthcare communities, surrounding townships, and the University of New Mexico to figure out what is happening and what can we do to safeguard our communities. For those of you that remember, this 1993 hantavirus, this Four Corners disease, was causing people to die, just as this virus is doing right now. And these are definitely matters of life and death, and we need to be talking about it. I don't want to take away people's sincere conversations and feelings that they're not trusting the government and what's happening. But as you've heard from Dr. Ignace, this vaccine isn't centered around just Native people. You've heard him talk that this virus is going out to everyone. So that's one. We need to have these honest conversations. We also need to talk about, if history is an indicator of what's coming in the future, we have in our most recent history a successful work product of getting ahead of the hantavirus and getting ahead of people who were perishing because of a disease that just was so, and it was an aerosolized virus, just as we're dealing with now, that was far more deadly. And it caused rapid fatalities. So we succeeded together. They looked with cultural people, they looked at health experts, and they succeeded, just as this one is, I'm hoping, going to succeed. I just want to say a couple more things here. As our Native community has faced this, we've faced this together with the government. So what do I mean by that? As I look at what has happened just from the Gerald L. Ignace Health Center, we've had 52 and a half hours of on-air conversation about COVID-19 in our community. We've had about 131 and a half hours of prep time to go into these programs, and that's just for one person. Multiply that by staff and people that help us. And I also would say that in total, that's about 184 hours dedicated to the health of our community. And now what's coming forward out of all of those hours and dedication and working with the Native doctor here, Native to Native conversations, is now we have a place to begin a good conversation, which means people need to say, I'm uncomfortable with this. People need to say why they're uncomfortable with this. And we need to come up with answers directed towards them. In a segue to the question here is someone wondering, why are trends changing so much per state? We've dealt with this question before. It's a great question. One of the answers that's come forward in our previous shows is population density, meaning people interacting with each other, they're living next to each other. And in rural areas, that it may not be as people may not be living as much together, but our tribal traditions and ceremonies bring us together in tight circumstances where what could have been a protective factor of having distance between each other, now it becomes something that makes us vulnerable. Are we seeing that now? I don't know. I think that's why this stuff needs to be studied, but I want to turn this over to Dr. Ignace for him to weigh in, because it's a legitimate question, because it informs us what to do. Native people live in rural and urban areas. There will be concentrations that are different from one community to another. So Dr. Ignace, here's the question. Why do you think that trends change so much per state? Like looking at California as the example. We'll go to that question. We'll go to the next question after this. Dr. Ignace?
Yeah, so it's kind of an interesting question, because population density certainly plays a major factor in the surge of cases. And up until about 4 weeks ago, 5 weeks ago, Wisconsin would seem to us as being the only hotspot in the country. We knew about California and Florida and Texas. Yeah, they're going to have their cases, but for Wisconsin to be in that same discussion, why did that happen? And it's hard to say as to why that happened. It's not like Wisconsin has a higher population than these other Southern California, Florida, Texas states, or even Illinois, but it happened, and it happened all at once. And in that short period of time, it really kind of speaks to how contagious this virus is and how it can be, and the logarithmic expansion of this. One case of one person in one household goes from one person to 4 people, and those 4 people can spread to another 4 people, and before you know it, you have this exponential growth, and it's rapid, and you can't do anything about it. You can try to slow it, and we've all done that with mask wearing and distancing and limiting our contact with others. But I think for Wisconsin, it was perhaps our time to go through that surge, and we did, and then everyone else followed after us. So just like, if you were like on a trampoline, one spot being the bouncy, well, that's what we were. We were that major spot, and then it rippled out to our neighboring states, because Wisconsin was high, the other states were low. As we were going down, they were going up in the northern plains. So it had that rippling effect as it went out. But once it goes through a community, it doesn't just stay and expand and expand and expand. It goes and it spreads. And once it's done its spread, it dissipates. And there's still some residual of that still in communities. I think the hardest part, once we get into more rural settings and we get into more tribal communities and counties, is not that the message hasn't got there. I think the message is very quite clear. Everyone knows what they need to do. It really is a matter of how well they do it. Individuals may be strict, absolute, and they're probably not going to get the vaccine. Whereas people that may be a little less strict about their protection to themselves and others, yeah, you know what? There's just so many things you can dodge before it actually gets to you. And I think the rural communities, I think because they had not been impacted up until most recently, perhaps felt a bit of invincibility, feeling invincible to a point of being a little cavalier. But now it has gone through and it's gone out of the communities, and that's where the impact of devastation can occur. Now, I think the coastal cities, California's East Coast, West Coast, I don't think California ever went through a surge. They've kind of went through this, little wave of cases here, cases there, but they really haven't gone through a wave. Not like Wisconsin just went through their wave. This is what California is going through now, is what we went through, 5-6 weeks ago. We're on the back end of it. California may be still in the beginning of that phase, and they need to go through their surge, much like how we did. And so places like New York, New York was the first place to be impacted in the United States, big time. And then they decreased and they maintained that level, only to now have it resurge again. And it's going to resurge again in New York without a question. It's just how high will that how high will that water rise to? And I don't think anyone really knows. But again, and because of the density, population density, it just spreads so much faster than, let's say, Wisconsin, where it was just kind of this slow progressive wave that just slowly came on us to a point where it got really critically high and then it receded. I don't see that receding occurring as rapidly as we have, because it will take time for higher density populations to recede, and it may take months for California and places like New York to go down. So
yeah, I want to grab a couple questions I got when I was just in Kashina. So two different people, two different questions, but related. One is a person has allergy to eggs. Is they haven't heard anything? Is this vaccine kind of related to that? Some people don't take vaccines because they have severe allergy to eggs. And second question is, how does a person know that they're going to get a mask? This person working at a gas station. I'm sorry, how did the person know they're going to get a vaccination? They're working at the center. They're not tied to the tribe. They're working at the gas station. They got contact with loads of people every day. So far, so good. But they're just like, man, all this is on the news to me. There's nothing real about it. So what do you have to say to folks on those front lines?
Yeah, so it's kind of interesting. As you become that phased group in, that next round of people who would be eligible to get the vaccine, what I'm hearing is, should someone, let's say, with a allergy to eggs, and whether or not the vaccine, or should they get it, or even community members who've been exposed to community on a high level frequency every day for months on end, and they've never been sick, are you asking about should they get the vaccine, Mark?
No, the question at the cash register was, hey, good job, guys. One, but the second one was, how do I know when I get the vaccine? That person behind the register got no relatives at the tribal clinic, not connected to legislature. They're just slinging their job every day, trying to do it. And they're like, well, what about me? I may have an opinion whether I want to take it or not, but when's my shot? How am I going to know? Who's going to say? Is it just watching TV on the radio? They say my name, or so that's the question: is how is this person going to know?
Yeah, it's going to vary between where a particular individual actually may work. So let's say this, if we're talking about vaccines for, let's say, a tribal health center, and they're within that agency, health agency, they may view everyone as being essential workers, and that's how people get scooped up into a category, and how they get categorized into a phase. And that's where this whole discussion I mentioned, there would be a phase 1A, phase 1B. Now there's going to be a phase 1C, and that's where this kind of other essential work group in the health agency will be scooped out. If you don't fit into any of these scooped groups, and let's say you're 40 years old, you have no health problems, and I, work at a gas station, well, your group may be a phase 3. You may be categorized into a phase 3 with the general population. And so that particular individual may have to wait till April to be eligible for a vaccine. It all depends. It really will, because we may get through phase 1A through C really quick. We get into phase 2 and high-risk individuals, 65 and older, and we do very well in vaccinating people. This date of April may soon become, let's say, March. It really will depend on how quickly the population, the general population as a whole, is willing to take this vaccine. And that's the million-dollar question: is the population as a whole, who's gonna get it, who's gonna want it, and who's gonna get it when they become eligible for this pandemic to come to a halt. And that's going to be the question, because we know there's 60% of people right now are now saying when the vaccine becomes available to them that they will take it. About 25% said absolutely not, and then we have these in-betweeners. Well, that's a big shift, and even from a month ago, where it was more like 60-40. I'm sorry, 40-60. 40% said they would take it, and 60 would rather wait or not take it. Well, that's starting to flip now, and I suspect they will continue to flip even more as more and more people become vaccinated and express their experiences.
I know we're trying to stay to 4 o'clock. We're past that, so
that's fine.
Just a couple questions. One is I ran into someone who's very religious, and their pro-life stance is such that they want nothing to do with anything that has to do with unborn babies, that their life is terminated as they see it, and so I get that, but it extended to the point with an odd conversation where she said, hey, how they make vaccines is from aborted babies. I was like, I get that we can understand, but that's the kind of thing that's out there, is that vaccines were developed from fetal tissue, and that this vaccine is developed from fetal tissue, and so wants nothing to do with it. So I'm just hoping you can kind of, and that is the question that's out there in our community that's floating around, is this kind of stuff. So I'm going to turn this over to you and, address that one. That came out of nowhere, but it was legitimate. She asked it, and so I will ask.
No, so, if to get down to how this vaccine was even created, as, in my very first slide, it's based off the messenger RNA, which is a new platform on developing technology. It has nothing to do with fetal tissue. It has nothing to do with any unborn anything. That if that's out there, that's just, it doesn't even make sense how that could even be worked into the basis for this vaccine. It's just different technology. It's based on the RNA of the virus itself and nothing else other than the virus, coronavirus. And so, this vaccine is based purely on the genetic disposition of the RNA of the virus and nothing else.
All right, so that was pretty straightforward.
Put that one to bed.
All right, here's another one. It came out of the same, sitting by the sodas over in the station. Oh, hey, let me jump in on this. And this was a dad that thought, hey, now that this vaccine's coming out and kids aren't getting vaccinated, I want my kid to be safe and whatever. And they say, hey, let's maybe we should get our kids together and have a COVID-19 party for kids. Because hey, adults are getting vaccinated, kids aren't, And if they're not going to get affected, my kid might as well get it now. Then I don't have to worry about it later come spring or after this break. Was the idea is let's get kids together around this. So you never know what you run into, but hey, as I said, let me ask, is it a good idea to have a
No,
kid
it's not.
party?
No, it's not. Don't do
can
that.
you just
We
say
already did that
why?
experiment.
You just say why. If you could do that, that'd be awesome.
All right, so we already went through this kind of the social natural experiment already, and it was called college campuses, and some of that didn't go over too well, and you had these major outbreaks of COVID to a point of a party, or you could say a vaccination get COVID party from maybe 1 case to 300 cases in a week. That's a pretty hard burden on families, not to mention on the kids. I don't recommend it. If you can avoid it, it certainly can be done, and there wouldn't be any benefit, because there's always that risk that someone can become overly ill, and that's concerning, because obviously we don't want to get sick. We don't want to get COVID. We certainly don't want our kids to get COVID, and it's not. It doesn't benefit even your kids to get COVID, even though they may not be harmed from it. They may get mild symptoms, but you just don't know. You just don't know who that individual may be that may get sick. And I certainly wouldn't want one of my kids, if I can avoid it, not to get it, and certainly not intentionally try to get it. That doesn't make sense.
So this seemed to be, and this was the last in that little clutch of conversations near the refrigerated
What
section.
gas station did you go to?
Man, I'm not saying, but it was hopping. It was hopping. So this was good though, and I was like, hey, that's all right. Is there a phase 4 to these vaccines? Because they've heard of 3 phases, and by phase 4 they said, are we phase 4? Meaning that, hey, I get a shot, now I'm going to get tracked by the government, which goes to that I don't want to do this because this relates me to the government. You never know what to do with this information. So now I get my shot. I got, like I can see it, all now. Someone's going to say, hey, man, they gave me a card. Now they're going to track me. Then they're going to give me a second card and track me again. Man, I already got a tribal ID. Now they're going to track me in a different way. So
yeah, I got a driver's license. Now I got tribal ID. Now I got my COVID vaccine passport.
Yeah, and that means that I get hired or not hired. So, so go ahead. Yeah.
I don't know how this is all going to play out long term, because the notion here is if we're just looking at COVID and not kind of a life altering change of systems of how we even travel from one state to another or a different country, but right now I think the assurance, either it be the CDC or Department of Health and Human Service, they want to track how this vaccine is getting out. And obviously they have the interest of public health safety in mind here, and being able to track all the vaccines that go out. And if anybody does develop adverse reaction, is that they can actually identify in short order where and when, in what vial, and by which individual. So they have a tracking system in that regard. It's not meant to track people individually, and maybe at some point, let's say in the immediate short term, let's say in the next 3 to 6 months, there may be state restrictions that will prevent travel unless you have this kind of validated vaccine card that says, yeah, I got my 2 shots, and but I think that would be the extent of this. I don't think there'd be any long-term tracking of how people how this information is gonna be used to track people in a negative manner.
All right, so this will be my last question for our session on this one. And this is, it's about lockdown orders. So I know that's being discussed right now, State Supreme Court. I think we covered one, if you do get the shot, you still have to do a mask when you're in public. But, you know, if there's a lockdown order, then, hey, I got my card, and now I don't have to do that because I'm good. And related to that is, it was a director of a nonprofit, much like you, and the question was, is there any conversation that you've heard of on the health side about health insurance companies ramping up people's health insurance if they don't get a shot? So I'm just putting those two together because I want this to be my last appearance on screen. Hand it off to you, and Jeremiah has any questions to get to that. So Dr. Ignace.
Yeah, so I haven't heard the back end of this of health insurance and whether or not how they're going to set the premiums on someone who does or does not get it. And in fact, that doesn't seem like a legal thing to be able to restrict or raise premiums on individuals like that. I'd have to look more into that. I just have not heard of that before. But I will say, just as a side note to this, and this may be a question that's going to come up as well, is, once I get the vaccine, can I just go and burn my mask? Well, no, you can't, because it's going to take time between first shot, second shot, whether you get Pfizer or Medurna, and your protection that your immune system will build. Now, with Pfizer, we know that people's immunity starts being built up in their system, and the earliest time frame of exhibiting some type of level of protection starts at day 7. By day 10, it's been shown to be at least 50 to 52% effective in preventing COVID. It's that second dose, and that is that booster second dose at day 21 that people will go from 52% protection to 95%. It's that second shot that you need, but it takes 3 weeks to get to that point. And after your second shot, it'll take at least 7 more days till you get to that. So it's going to be a month, 4 to 5 weeks before you get to this. So you're going to, between now and then, you're going to need to wear your mask. You're going to need to continue these social rules that we have in place now before you get to that level. So there won't be any mask burnings going on, anytime soon for anybody. Now, the other thing on top of that, and I didn't mention this before, was that Medurna. They didn't mention this in the Pfizer profile, but in Medurna, they say that it is 60% effective in reducing the transmission of the virus, which basically is saying, I get the vaccine, I have a level of protection. Can I still transmit the virus? And Medurna is saying, no, 60% of the time you will not be able to transmit the virus after having the vaccine. So now I don't know if Pfizer actually looked at it or has the data to support that like Medurna does, but that is what Medurna is saying. And I'm assuming that's the same thing with Pfizer as well. So
it sounds a lot like, well, 60% of the time I got a gun in my house. So burglarize it and see if you're at the 40% level. So,
60 is better than 40.
So this definitely will be the last question, and we're going to have you have the last words for this program. Thanks for going the extra half hour here, but this has created more and more questions rather than there is a sense of unease out there, and I'm hoping we're addressing it. The singular question that this comes down to is this a cure for COVID-19? And by cure, you know, that could mean lots of things, but just from a medical perspective, when someone says cure, what is your sense of, hey, this is a cure for COVID-19 in our human population? And Dr. Ignace, you have it the rest of the way.
Yeah, so what this may be touching on is a couple things. One is kind of this natural immunity that we occur after being exposed to something, and then this immunization immunity that we get from, let's say, with this vaccine, we'll have this kind of this technical immunity created as a result of the vaccine. This is going to be an interesting question because we don't know. And right now, the general sense is that this vaccine will create an immunity that will last a year, at least 12 months. So could this mean that we'll be looking at additional vaccines in the future? That has yet to be determined. Now, when we talk about natural immunity would be, you know, I got the flu, I recovered, I developed an immunity to that strain of flu. How long will that last? Well, the general sense of that type of immunity, that natural immunity of after having just gotten and recovered, lasts about 2 years. And the reason why I say that is with the other coronaviruses that are out there that basically cause the common cold, the sense is after studying the other types of coronaviruses that are out there, that natural immunity lasts up to 2 years. Now, what's better? Is it better to just get it and recover and have immunity, or a vaccine? The answer is it could be very well be both. Now, whether one is 91%, the other is 90%, it really doesn't matter. It still protects individuals quite well when you get up into those ratios. So with that being said, I know we're at the end of our time here, but that light at the end of the tunnel that I've been speaking about for the last several weeks we are there. The light is bright. We have Pfizer, we have Medurna. We're going to have other vaccines that not just for a small number of people, but for the entire country as a whole. For all genders, all ages, all racial, ethnic demographics, the vaccine is going to be available. I shared my experience by getting the Pfizer vaccine, very minimal at best, nothing that I was concerned about, nor would I have concern if any of my patients were to receive the vaccine. And I certainly don't have a problem recommending any Native community to get vaccinated. In fact, I would strongly recommend it, particularly individuals who are of older age, who are elders, who have multiple risk factors. It's going to be that much more important that you look at yourself to be vaccinated. This is, again, looking at prevention. We want to prevent people from getting sick, getting ill, going to the hospital, or even preventing a poor outcome. The time has come, and we have that opportunity to make a difference, make the difference in our families, make those differences in our communities, and as Native people, this is going to definitely benefit our population. So with that, continue to follow social distancing, 6 feet, wear a mask, wash your hands. When you become eligible for that vaccine, please consider taking that vaccine. It could certainly help not only you, but also your entire family. So until next time, we'll talk again. We'll have more information next week. So everyone, be safe and stay strong.